disorders, you are going to come across patients that have these cognitive disorders and disabilities with the psychological component. So it's important to know that the mental process of acquiring knowledge and understanding through thought, experience, and senses is the meaning of cognition. That's what cognition means. When you have a patient that has cognitive disability, that patient, do you expect them to have more difficulty with performing any activity?
Yeah.
Absolutely. So just know that that person is going to have a greater difficulty with either one or more of the mental tasks that you give them. Perfect example, I was just working with a patient, cognitively there, I was having her do a puzzle while she was standing. Why would I have her do a puzzle while she's standing? What am I working on there? Weight bearing, balance, right? I'm working on her balance. Without her knowing, we're just doing something fun just as a puzzle. But without her knowing, she's actually working on balance, she's working on weight bearing. Now, with this patient that has a cognitive issue, will they be able to do that puzzle? No, probably not, right? So it's just important to know that that person, you probably can't put that person to do a puzzle because they're going to get frustrated and the puzzle is going to end up on you, right? They're just going to toss everything away towards you. Most cognitive disabilities have some sort of basis in the biology of the individual or the physiology. So something must be going on with that patient that is causing this cognitive disability. Is this my second slide? Yes. So a person with a profound cognitive disability is going to need assistance with nearly every aspect of daily living. Sometimes we go into a patient's room and they had a traumatic brain injury and they're not even going to know what it is to get out of bed, to roll to the side. So that person is going to need more of help from you. It's going to affect their everyday life. Somebody with a minor cognitive issue is going to be able to function accurately despite of the disability, perhaps even to the extent that the disability is never discovered or diagnosed. So this slide is just telling you that there's different disabilities that will cause different effects in a patient's life. If the disability is major, it's going to affect them in a major way. If the disability is minor, sometimes the patient will function perfectly fine or not be affected at all. Right? There is a wide variance among the mental capabilities of those with cognitive disabilities. So what is the biggest thing that you think you have to have when working with patients with cognitive disabilities? As a PTA coming in,
Patience.
Patience. Patience is your number one. Same thing that when you have to work with children, patience. Same thing that when you have to work with patients with dementia, Alzheimer's. You tell them about the precautions about the total hip replacement, and 5 seconds later, boom, gone, out, and they're already crossing their legs, and they're already reaching down. So it's just constant repetition with these patients. Do you think that if I go in to treat a patient with a cognitive disability, I have to speak in a really loud voice? No, there's nothing wrong with hearing, all right? So it's not like, oh, my name is Martin, I'm here to treat you. No, normal person. Let's say if you go into a room and you're treating a patient with cognitive disability and their husband is next to them. Are you going to just direct your questions to the husband, not to the patient? No, to the patient. All right, the patient is always the one that you're directing the information to. When would you give the information to the patient's husband?
When he's a minor, maybe?
When it's a minor, right? Hopefully they're not married, right?
If the cognitive disability is like maybe like bad enough when you need a consent of someone.
Exactly. So consent. It can be consent in the medical record. It can be verbal consent from the patient. So most of the time it's going to be from the patient themselves or the medical record. That's the only two options where you're going to direct. You're still talking to the individual, but you're going to direct to get the answers from the family member sitting or standing next to them. So clinical diagnoses that may result in cognitive disabilities, which some of you have already learned about: autism, Down syndrome, traumatic brain injury. Now it's not termed traumatic brain injury; it's called acquired brain injury. But you may see it both ways. Acquired brain injury is the same thing as a traumatic brain injury. Dementia and less severe cognitive conditions include ADD, dyslexia, and learning disabilities in general. Clinical diagnosis will be useful from a medical perspective for treatment. But when we are treating the patients, are we really going to be looking at the main diagnosis, or are we going to be looking at the functional capacities of our patients and see what we can work with? That's what we're going to be focused on. The main diagnosis, yes, it's there, it's the patient's diagnosis, but this will help mostly the doctor kind of formulate that patient's treatment. Us in PT, we really don't focus on that main diagnosis, but just what are the signs and symptoms and the impairments that the patient is left with. Any questions so far? Am I going too fast? No? All right, so functional cognitive disability. This is what it can affect in patients. So functional disabilities is what we're looking at as PT professionals. We look at the disabilities that ignore the medical or behavioral causes of the disability. So we're not looking at, oh, this patient has autism. We're looking at, okay, so the autism is causing all of these deficits and all of these things here. They have memory deficits because they have dementia or Alzheimer's. They have issues with problem solving. They have issues maintaining your attention. Brandless, how is this going to affect, you're treating a patient with an attention deficit. How are you going to make sure that your treatment is successful?
How am I gonna make sure that
Let's say you're working on ankle pumps 3x10 and your patient does one, they're like, just looking around, stops doing their exercise. So what are you gonna do?
correct them?
Correct them, right? Constant reinforcement, constant re-education. Okay, so what number are you on? Let's count together so that we can make sure that we focus on this type of exercise that we're doing. So count with me. 1, 2, and you're just gonna have to be super involved with that patient. That's not the patient that you're gonna be, okay, ankle pumps, I'm gonna go to another patient now, because that patient's not gonna get any benefit from you there. Okay, so good. There may be problems with reading, with linguistics, language, and verbal comprehension, and visual comprehension as well. So all these things we have to keep in mind when we're treating patients. I had to treat a patient once that was blind and deaf. So how am I going to get that patient? We were doing gait training, and the patient had to have a hemi walker, which is a walker that just goes on one side of the body. What am I going to rely on? Touch, tactile cues, a lot of tactile cues. All right, so that's how I communicated with that patient. And you just don't have some of the senses, therefore you have to heighten some of the other senses that are there. Yes.
No, there's a bunch of questions after that. I'm sorry. So that person is supposed to learn to the braille, or there's another term
Braille?
for them because
Braille, yeah.
how
So
how will you let them know what each thing means because it is deaf
So
and blind?
basically, that was a lot of okay, guiding the patient, because there was no way for me to communicate verbally or visually. So it was just a lot of guarding, and that patient was able to walk. That kind of goes beyond what we're doing. We cannot fix that the patient can't hear. We can't fix that the patient can't see. So yes, they're going to have to go to a specialist that maybe teaches them how to use the Braille system so that they can better ambulate and better function in life. But our goal was to get him up and walking, just to increase that function. At home, it was going to be something completely different. This patient was going to have to go home with a 24-hour assist until they got used to their new normal. Okay, so a lot of times it's not that extreme. It's not going to be vision and hearing that is affected. It may just be one eye that they can't see because of a stroke, or it may just be hearing affected. But that was a little tough. I was like doing the exercise, and then I would just kind of have him do the exercise, and my hands were like on him so that I can tell him that we were still doing the exercise. Because I couldn't tell him we're going to do 10.
Yeah.
So it was just a lot of tactile cue and running him through the entire session. Yes. You got a question?
Are those people more from, I don't know, I just think, you have to like watch them more carefully, not even just so that they don't do things maybe to harm themselves.
Absolutely, yeah. Absolutely. So, yeah, that kind of, I'm going to talk a little bit more about that. If a patient tells you, because I've had patients tell me, I don't want to live. I don't want to live like this. So what do you guys do in that case? You just don't motivate them, but is that like a red flag that you need to tell somebody?
Yes.
Yes, your PT, you need to document it in your chart. But each facility that you end up at may have a different protocol of how to deal with that. So always check with your CI when you're a student. How do I document if my patient says that they're going to kill themselves or something like that? Because I've had patients tell me that. And we would just put it in the chart, notify the PT, put in your chart that the patient may need a psych eval, so that psychology will come in and do an eval and get him the help, him or her the help that they need. So always.
Sorry, what will you tell them when they tell you that?
So yeah, discourage them from those thoughts. Okay, you have so much, you're doing so much better. You have to keep fighting. You have to keep getting better. In therapy, I've seen you a couple times and you've improved so much. So I don't want you talking like that.
Even if it's not better.
Even if it's not better, just give them a little bit of hope. You're not going to lie to them and say that they have a spinal cord injury at C5 and, oh, you're going to be fine. You're going to be walking in a couple weeks. No, we want to be realistic, but we just want to give them that little push. Okay? Yes, we don't want them to hurt themselves. So memory refers to the ability of a user to recall what they have learned over time. A common model for explaining memory is the concepts of working memory, so immediate memory. If you tell me to do something, I'm going to do it right away. That's my immediate memory. So let's say you tell me how to get out of the wheelchair, and you ask me, okay, so can you do it now? That's immediate memory, because you just taught me this, and I'm going to do it right back, and I'm going to teach you back how you taught me to do it. Short-term memory is going to be that retaining information for a shorter period of time compared to that long-term memory, which is I remember something from years and years ago. All right, so just know, as far as this goes, I need you to know the meaning of memory, which I'm sure you know, and just the three types of memories. We have the working memory, the short-term memory, and the long-term memory. Some individuals with cognitive disabilities will have one, two, or even all three of these types. This thing again. Okay. Some individuals will also have issues with problem solving. So this now I'm just going into detail of all the lists that we talked about earlier. So a lot of patients will have who have cognitive disabilities will have a difficult time solving problems when they arise. So in many instances, the perfect example that I can give you is that person that you had doing a puzzle. If the patient puts one piece together and then like 10 minutes pass by and they still haven't gotten the next piece, what are they going to do? They're going to get frustrated. So their level of resilience, their ability to kind of withstand the mistakes that they're making is going to be super low. So that patient is not the type of patient that you need to be putting to do puzzles or do stacking blocks, because they may just get super frustrated and then that's going to add to the problem. Okay, they may even just not want to do therapy for the rest of the day, and that's not good for your productivity. Attention, so there may be individuals that have difficulty with focusing their attention to the task at hand. Some people with ADHD have difficulties learning, but oftentimes it is due to their distractibility. You have a patient, let's say you have a child that has ADHD diagnosed in the chart. It's not what you're treating them for. But now, how do you think you are going to better kind of formulate your treatments so that the patient is not distracted?
You have to be very engaged.
Very engaged, but let's say, are you going to bring this 5-year-old or 6-year-old into a room where there's
No.
7 more patients
No.
playing with all the other toys in the clinic? So no, they probably would have to bring them into an individual room, isolate them so that you can bring just the things that you need into that room. So that's just giving you little ideas of how to work around all of these disabilities. And people with ADHD can be impulsive, easily distracted, and inattentive. So you're just going to have a lot of patience with those patients. There's going to be issues with reading, linguistic, and verbal comprehension. So some individuals will have difficulties understanding text. These difficulties may be mild or severe, ranging from minor challenges to a complete inability to read any text. this may be due to them not being able to understand non-literal text or non-existing text. So non-literal text is, let's say that you're trying to be sarcastic with your patient and they didn't do such a good job, but you're like, that was amazing what you just did. Like you're being sarcastic, they don't understand it, that's going to cause a problem. Or if you're trying to make fun of somebody, let's say that you're working with a patient sitting down, and then there's another patient that passes by, and the patient like almost trips. Oh my God, you saw that? And you almost tripped. Like parodying somebody. You guys would never ever do that, right?
No.
Okay, good. So this is like the way that the patient is not going to realize that the words are really not meant to be understood very literal. That you're trying to play around with that patient. And yes, you can be sarcastic with your patients. At what point can you be sarcastic with somebody? Or like use jokes or stuff like that to kind of lighten the mood.
If they use it towards you.
If they use it towards you, and if you have become comfortable with that patient and you feel that you can take it to that extent, you'll see these patients. I've treated patients for like a year because they just kept coming back for different things, and with that patient you feel comfortable. Or even after a couple of visits, after a couple of weeks, you may feel comfortable with that patient. But you just kind of have to take it on a case by case basis and see what you can and cannot say with these patients. Non-existing text. So with that said, I don't want you guys to start regarding the obesity thing that was covered in the last lecture. You never want to tell your patient, oh, you need to stop eating, you need to stop doing that. You always have to kind of step around those things and really be careful with the way that you word things, because it takes a split second for that patient to be upset.
Nowadays, like I feel like patients could get easily upset about everything.
And they do.
So it's like,
And they do.
especially when you're talking about a really delicate topic like is obesity,
Yes.
like it's a really touchy subject. So
Mhm.
even if you're like trying to talk to the parent of that person that they need to start exercising and do a little bit more, so they increase the chance of being a little bit more healthy, they're gonna take it in a wrong way because no one likes for someone to tell their child that they're obese, but
That's
it's just like reality, the
Yeah.
fact.
So what we can do is we can, with that scenario that you just gave, we can give the facts of like, okay, obesity does this, this, and this to people in general, not necessarily directing it to that patient, just so that they know the bad things and the well, bad things only with obesity. But we never know the patient's circumstances and how they got to where they got. So that's what we really have to take into account. Like we don't know if there was depression, we don't know if they just had a major life effect, a divorce, something that kind of put them or threw them into that direction. So always think of why did they get here? They were not born like this. So you just have to keep that in mind.
Or hypothyroidism.
Or hypothyroidism.
Yeah,
Right.
they have a medical condition.
Question?
Yeah, I'm saying that usually it is something that,
Yeah.
usually it's not that they want.
Yeah, of course.
If it's a child, it's usually the parents. The parents are speeding it.
So it could be just upbringing and yes.
But if they made the step to go to physical therapy, you would assume that, but like, they would want to get better at that point,
Yeah. But it also depends on like some majority of patients they go to therapy when they have pain and they can't deal with that pain. So that's kind of pushing them towards that. And of course, if we see that somebody is has obesity or suffering from obesity, then we can definitely put two and two together as clinicians that this is what caused this because of all the excess weight that you're carrying. You tripped and fell because and you weren't able to maintain yourself upright. So it's like a little of domino effect that you have to really kind of investigate what's going on and why it happens. Non-existing text is the unstated assumption and implied meaning of written content may seem obvious to the writer, so but you're expecting your patient to read between the lines and they're not getting it. So this is the issue with non-existing text. You're trying to write something, but you really don't mean what you're writing. You want the patient to read between the lines. Have you heard that phrase before? So once again, non-existing text is reading between the lines. That's what I want you to recall from that. And non-literal text is that words that you're telling the patient that you don't expect them to understand them literally. Okay? Kind of like a hidden message. Some individuals may have issues with processing visual information. This can be due to a CBA or any of the other conditions that we talked about earlier. Individuals with visual comprehension difficulties may not recognize objects for what they are. When we when you guys go to rehab, you're gonna see all the effects of a patient after a CVA, and sometimes individuals are not even able to recognize their own family members because of the visual deficits that they're having. As of now, I don't need you to know that. I just need you to know that there can be visual deficits with psychological disorders. Cognitive disability. So what does it mean to us? What does it mean for our PT patients? Cognitive impairments is not caused by one disease or condition, nor is it limited to a specific age group. This does not discriminate. Alzheimer's disease and other dementias, in addition to conditions such as stroke, traumatic brain injuries, genetic disabilities such as Down syndrome and autism, can cause cognitive impairments. You guys learned about Alzheimer's during the neuro? Okay. Do you recall that? Huge lecture. So common signs and symptoms of common signs of cognitive impairment are memory loss, frequently asking the same question. That is called perseveration. Perseveration. Your patient is sitting in the chair, and you come in and you introduce yourself, and the patient continues to, what's your name? What's your name? What's your name? Your name? What's your name? So what are you gonna do? What's your name? I keep asking you, what's my name? No, that is a wrong answer because you just need to answer twice at the most, and you need to move on to something else. What you need to do is to try to redirect that patient to a new task, a new activity. Okay, so you answer twice and you say, okay, now we're gonna go ahead and we're gonna go to the gym and we're gonna do some exercises. If they keep saying it, you've already answered that. So try continuously to redirect that patient to a new task or activity at hand. But our biggest thing would be, our like layman's thing would be to answer every time, right? Because we don't want to be rude. We want to continue to answer that patient. But no, we want to redirect.
What you do if the patient, for example, say you that I'm not gonna go anywhere until you say me your name.
Okay, so what tactic are you going to use there? What tactic are you going to use there? Not sedation. All right, Rachel, I'm gonna see no cognitively disabled patients on your schedule. Kidding. I know you're kidding. So you would answer maybe a couple more times. Hopefully by that time you're in the gym and doing something else. But the biggest thing to do here, the biggest takeaway is redirection to something different. Okay. Yes, I may have answered a patient more than 2 times. That's not like a rule that is set in stone that you need to just do 2 times and then ignore. But just redirection is what I'm trying to get at. They may tell you the same story over and over. So you may be working with this geriatric patient that has Alzheimer's, and they're going to tell you the story of how they met their husband 10 times. All right, and you're just going to be super surprised every time. Oh my God, yes, it's awesome. So that's how you're going to be. Not recognizing familiar people and places. We talked about that earlier. Having trouble exercising judgments, such as knowing what to do in an emergency. So your patient may be slipping off of the bed and they don't know how to problem solve, so they just end up falling off of the bed. Changes in mood or behavior are going to be present, visual problems, and difficulty planning and carrying out tasks such as following a recipe or keeping track of monthly bills. I want you to put next to this, keeping track of monthly bills and following a recipe. They are called instrumental activities of daily living, IADLs. Right, so just make sure that you know that. You'll need those when we go to test and measures. Instrumental activities of daily living, IADLs. Driving a car is also an IADL. So risk factors and treatment. The risk factors, family history, education level, brain injury, all of these are considered risk factors to the development of psychological conditions. Physical inactivity, chronic conditions such as Parkinson's disease, heart disease and stroke and diabetes may all lead to issues with cognition. Cognitive impairment can also be related to health issues that may be treatable, like medication side effects. Somebody has a deficiency in vitamin B12, it's also linked to cognitive issues, as well as depression. It's important to identify people who are showing all of these signs or cognitive impairments to ensure that they are evaluated. So what Alicia said in the prior lecture is very, very true. You have to be cognizant of how your patient is presenting. Not only are you going to treat that patient for total knee replacement, but you are going to see the entire patient to see what is going on and what you can do to help, or what you need to do to alert the PT, to alert the physician. So it is important to also know that as physical therapist assistants, we really don't focus on the treatment of the impairments directly, but we focus on the decreased memory, on the decreased problem solving, and how we can attack those with our treatments, and how we can tailor our treatments to kind of work around those impairments. The mini mental state exam you guys have talked about before in neuro. So just knowing what the mini mental state exam is what I need you to know for this final exam. It is a sensitive, valid, and reliable 30-point questionnaire that is used extensively in clinical and research settings to measure cognitive impairment. It's commonly used in medicine and allied health to screen for dementia. So I just need you to know that it's a survey that screens for dementia. Okay, and then the next slide is just kind of giving you a little bit of an example of the mini mental state. You can do it on yourself if you'd like to see if you have dementia. One thing you guys do, you guys are all doing well in the course. You can remember stuff. Any score greater than or equal to 27 points. This is gonna be testable not in this class, but in a class coming up. So I don't need you to know the actual scores. I just need you to know what the mini mental state exam is. So just to talk about it a little bit, any score greater than or equal to 27 points indicates a normal cognition. So I'm sure you will all fall under that score right there if you were to take the mini mental state exam now. Below this score can indicate severe, so less than 9 points, moderate 10 to 18 points, and mild 19 to 24 points of cognitive impairments. A maximal score of 30 can never rule out dementia. There has to be other exams that have to be done in order to give you a definitive diagnosis of dementia. And low to very low scores closely correlate with the presence of dementia. Orientation, you guys have talked about orientation in the past, correct? So alert and oriented times 4. What does that mean to that patient, Rachel?
That they have a notion of where they are, what time is it, like
Okay.
their name,
So everything
where
that's
they
on here,
eat,
right?
like everything.
So you go in there, you want to see if your patient is alert and oriented. And let's say your patient tells you what the day is, they tell you where we are currently. They say, oh, I'm in the hospital right now. What is your name? My name is Martin. And what is happening right now? Why are you here? I don't know, I just woke up here. So what is my orientation?
You're on a 4.
Alert and oriented times 3. Because I was unable to tell you that I fell down, I broke my hip, my family brought me to the hospital, I had to have surgery, and now I'm here. So this is the whole story of what has happened, or something that is happening in the world. Like there's a war going on right now, and this and that, and if it's true, then they are alert to the situation that is happening outside of the hospital. So everybody clear on alert and oriented times 4? Yes. So some strategies that can be put in place by you to enhance communication with patients that have cognitive impairments. You have to make sure that you provide the information in a very clear and concise manner, concrete, very, very simple. It's not that you're going to draw it out for the patient, right? Unless that's how they are communicating with every other individual. When necessary, you want to repeat information using different wording or a different communication approach. You want to allow the information to be processed. So you tell your patient, we're going to get out of the bed, and immediately start saying another question or another command, and the patient has not even processed that first command that you gave them. So it's important for patients with cognitive impairments that you allow the time that is required for them to process that information. Because it's not going to be as normal as we are without any cognitive impairments. When possible, you want to avoid jargon. What does that mean?
Excessive talking, like talking about anything that's nothing to do with.
So jargon is a specialized type of language that is used for a profession. In our case, medical language. So you wouldn't be talking in medical terms to the patient. That's why we have layman's terms, so that the patient can understand. So the jargon, we would be talking medical jargon if we were talking clinician to clinician. You wouldn't be talking medical jargon clinician to the patient or clinician to the family member, unless they're also a clinician. Right? So just make sure that you know the meaning of jargon. You want to break down activities into small steps. Question?
So if the patient is also has much training, then you could use.
Yeah, absolutely. So if the patient is a medical provider and they don't have a cognitive effect, then you can definitely talk to them in medical terminology. But here we're talking about cognitive, so they may not be able to answer you. Okay. You want to break down activities into small steps, and you want to present tasks sequentially. You want to allow the individual to perform each step after the explanation. So give me an example of where you can use this. Breaking down activities into small steps. Jessica.
Someone has a stroke.
Okay.
Break down the activities in the one.
What activity? Let's say you're in the hospital and you are going to take me from the bed to the gym. What are you going to break down for me so I can understand better?
First, I need you to sit in the bed.
You need me to sit in the bed? I don't even know how to roll to my side. How am I going to get to that seated position? There you go. So break down that step by step. So first, I want you to go ahead and roll to your right side. Then I want you to go ahead and bend your knees. Then you're going to go ahead and push off from the bed rail. So all of that has to be broken down. It's not just, oh, get into a seated position. And it's okay because you guys are going to learn that with bed mobility in the first week of the next course. Right? How we break down things so that we can especially work with patients with cognitive impairments. When appropriate, you want to use pictures or simple photographs to identify people, rooms, tasks, or directions. And you always want to think of creative ways to make tasks easier for the individual. Easier, but always safe. All right. There's things that we do to kind of cut corners sometimes, but for our patients, they're probably not going to be appropriate. So we always want to think of safety. Like this is the easiest way for me to get up out of bed in the morning is not going to be the same easy way for your patient that just had a stroke to get out of the bed in the morning. So always think that. Always think about safety. So continuing here, adults who have developmental disabilities, this is extremely important. They are adults. You don't want to go in there baby talking these individuals that are adults that have cognitive impairments. Like, oh, you're doing so great, buddy. Like, this is awesome. And you're talking to a 35-year-old patient that has a cognitive disability. They are adults. You want to talk with the patient, bring up topics that will be approached in general conversation. So you're not going to treat this patient differently from your next patient that has a knee replacement or a hip replacement. You're going to go ahead and just talk about what you would talk about with that patient. Talk about what they like to do in the weekend. The response that you get may be different, maybe sometimes inappropriate, but you still have to try to talk to them the same way. Talk about what they like to do on vacation, what's their favorite food, talk about the weather or any recent events with them. You want to address questions, comments, and concerns directly to the individual. This is very, very important for you to remember. We talked about that already. Not to a companion unless that individual tells you he's responsible or she's responsible for everything. So yes, you can direct the answers to them. This is another thing we talked about already. If someone needs you to speak louder, they will ask you to speak louder. They may ask cognitive disability does not mean that they are deaf. It's not any issues with their hearing. Now, if I had a patient that was hard of hearing, do I have to talk in a louder voice?
Yes.
Oh, pitch.
You don't talk louder. They're going to be able to read your lips because they've been used to that. Now with the masks, we have to raise our voice because the mask, they're not going to be able to see our lips, right? So that's the issue we've had with COVID, where now we kind of follow the rule of kind of elevating the tone of our voice because they're not able to read our lips.
How about patients who are deaf?
Patients who are deaf may be able to read lips,
No,
but with the mask, you mean? Yeah. So that patient may have a mask on, and the therapist may have to remove the mask. in order.
At that point, tactile
I haven't
touch-
had that issue, but yeah, I would assume that that's what it would be.
Tactile touch would be even more superseding than the mask at that point, because you're actually touching.
Mm-hmm.
So it's better just for the mask.
Yeah,
Maybe
definitely.
you can use a clear mask.
Yes. Yeah, those masks are a little weird looking, but I haven't seen that in the hospital at all. At my hospital where I work at, but yes, I've seen those out there where they just have that little clear window for your mouth. Yeah. So that's good. So people with cognitive disabilities may be legally competent, meaning that they may be able to make their own decisions. You want to rely on the individual to let you know if they must get someone else to sign any documents. Do not assume. Never, ever, ever, ever assume. So now we're going to talk about a couple of disorders. These are affective disorders that can disturb moods. They can disturb the patient's emotions. Intense emotions can become very intense and very unrealistic. So depression is one. We're going to talk about mania. Depression is slower mental. You should expect slower mental and physical activity. This patient is going to have very, very poor self-esteem. This affects a lot of patients, especially after spinal cord injury, stroke, those conditions that are very, very chronic and debilitating and that are going to affect the individual for the rest of their life. So you will have to deal with patients with depression. They're going to be sad, they're going to be helpless, and they're going to be hopeless. They're going to want to withdraw. They're going to be like, oh, I don't want to do therapy. What's this going to do for me? It's going to make me walk again. And that's where you come in and you have to educate them about the disease process and what you're trying to do with physical therapy. And what is the goal for physical therapy? Let's say for a patient with spinal cord injury that you know as a clinician that never gonna walk again. What are you there to do? What are you gonna do for me, Sebastian? Make me functional, right? You can lead a high quality life in the functional level that you are right now. So what we're here to do is we're here to train you, your family members, everybody that's going to be involved in your life to make you as most functional as possible with the condition that you have. It's going to be hard for that patient to accept, but that's the reality of things. And that's what we're there to do. We're there to make them functional. Mania, so patients may become manic. They will be constantly active. They're going to be impulsive, unrealistic activities. Disagreement with the patient may produce aggression in that patient. So during these manic episodes, this patient may even like try to punch you, or try to hurt you, or try to choke you. In the hospital, they say not to wear any necklaces because the patients that have cognitive disabilities and psychological disorders will just tug at anything when they become in this manic state. There's going to be disorganized thoughts and speech. Very few patients are diagnosed with only a manic disorder. So it has to come with some other condition. I like working with psych patients. They're fun. They are.
Maybe being sarcastic?
No, I'm being. Is that non-literal text?
Yeah.
Any questions so far?
What is it because they have,
I have a lot of patience when it comes to dealing with all of their cognitive deficits. So, yeah. Definitely. Guys, if you go out into clinical rotations and you feel that you get that rewarding feeling when you're helping these patients at their most time of need, and you're in the right profession. And you'll see that when you start working. If you ever have done any community service hours or volunteered at a place, you already know how that feels. That you have given a little bit to this patient's life to get them better. Continuing with the affective disorders, bipolar disorder, the patient will have alternating periods of depression and mania, so they'll just kind of bounce back. Depressive episodes, very, very low lows, and very, very high highs of manic episodes where they're just very, very impulsive. Females are a greater risk, sorry ladies, typically begins in patients' 20s. Now, neuroses refers to a group of disorders that are characterized by individuals exhibiting fear and maladaptive strategies in dealing with stressful or everyday stimuli. Obsessive compulsive disorder, or OCD, this patient is obsessive. Their persistent thoughts will not leave their minds. They become very compulsive, so they may have a repetitive ritual. behaviors that the patient cannot stop performing. So cleaning, you have to clean and clean and clean. And even when it's super clean, you have to keep cleaning that area. This is obsessive compulsive disorder. Unable to control irrational behavior, and it most commonly begins in young adulthood. And then we have anxiety, which is a state of constant high tension. They overact in certain circumstances and they present with apprehension and chronic worry. And they may suffer from those acute anxiety attacks. What did you say, Jessica? I heard something.
Before the exam.
That's what I thought. That's what I thought I heard. I told you, no, don't self-diagnose. Right? I don't think that's it. All right, then we have our other neurosis is a phobia disorder. So it can be excessive fear of objects, occurrences, or situations that is considered out of proportion or irrational. It's just an extreme fear. Arachnophobia, fear of spiders, extreme fear. Some classifications, it can be agoraphobia. Agoraphobia is just the fear of entering open space or crowded space. That patient will have very, very hard time getting out of their house even because they're afraid that they're going to be in these open spaces. Social phobia, that patient will not be able to go on dates because they're afraid to go out to the social scene. And simple phobia simply just is a term that is used to it's an umbrella term that it can be used to, that the patient is afraid, deathly afraid of a simple object or a simple thing. That's what that means, simple phobia. So specific object or situation.
So like if
You
someone's
just want to
like,
put that on there.
someone's just like, for example, someone's like afraid of the school.
Yes, yes.
Okay,
That will be termed as a simple phobia.
Can you repeat that? Agoraphobia?
Agoraphobia is where they're afraid to go out into open spaces. So they may be afraid to leave their house, is the example that I give. So do you think that the patient with this phobia disorder that has agoraphobia and you're treating them in a hospital room is going to want to go into that busy gym where everybody's working out? No. So then you may need to treat that patient in that room.
So, phobia is between that and
Claustrophobia
claustrophobia.
is
I-
enclosed spaces.
Yeah.
Yeah, enclosed spaces. So it's kind of like opposite. If you think about it that way.
For the simple phobia, what was the concept?
Simple phobia. So Ruben gave a really good example. Like, let's say you're afraid of utensils. So you're afraid of an object or a situation. So that was a good example. I'm sure there's no medical term that is the meaning for afraid of utensils. So it just you would just term it a simple phobia to spoons.
Okay.
That's what Ruben said. Yes.
What can help
I'm sorry.
what can
So all the factors that I talked about earlier, it can be genetics, it can be a condition that they're having, but we talk about these three specifically that may cause phobia disorders. So the three are experiences, so past experiences that you've had. Let's say that you were almost bitten by a shark when you were little, and that caused the phobia disorder that you cannot go into the water. All right, it can be through observation. You saw somebody getting stabbed. I'm being very extreme here, and now you're deathly afraid of going on the bus because that's where they got stabbed, or knives because the person got stabbed in front of you. And then classic conditioning. Classic conditioning is just associating something with something else. So let's say you're deathly afraid of a stove because you know that the stove produces heat. So you don't want to go near that stove. So that's classic conditioning. All right. You don't need to know classic conditioning, just know experiences and observation, but it's a very good thing to know because your patient may be telling you, why am I deathly afraid of this? And it's because I know that this is going to cause pain. Some patients can be deathly afraid of exercise because they did an exercise one time, one class, one time, and then they couldn't get out of bed. So that may cause a phobia. Again, not in patients that are cognitively there, but it may cause something like that in a patient that has a psychological condition. All right, the next one we talk about is schizophrenia. Schizophrenic disorder is a disorder which is psychotic in nature and presents with disorganization of thoughts, hallucinations, emotional dysfunction, anxiety, and perceptual impairments. You will hear stories from schizophrenic patients. So I go into a room and the patient's not talking to me. They say that they're talking to the person that is standing or behind me. there's nobody behind me or standing next to me. So they're seeing this other person there, and that is just their disorder. So it may cause, like I said, hallucinations, anxiety, or perceptual impairments. What causes it? It can be a traumatic event, genetic inheritance, biochemical imbalances, or environmental influences. So there are a couple of different types of schizophrenic disorders. We have a catatonic schizophrenia, which is where you have a lack of muscle movement or communication. So when you become catatonic, you're just kind of like frozen, right? Motor disturbances, there's going to be rigidness in your posturing. Episodes can also consist of uncontrolled movements. However, patients remain aware during the episodes. Medications are necessary to regulate these episodes. We have paranoid schizophrenia, which is delusions of grandeur, delusions of somebody following them. So you say the patient that you're treating and they have paranoid schizophrenia, they will tell you, so and so is trying to call the hospital and they're trying to know where I'm at because they're trying to hurt me. So that's paranoid schizophrenia. They may also believe that they have special powers, right? Disorganized schizophrenia usually is progressive and irreversible with inappropriate emotional response, or they may present with mumble talking. As of 2013, this is not listed in the ICD-9 book. So this is no longer considered a type, but these two definitely I need you to remember. What happened? I think they just bundled it into another type of schizophrenia because there's different ones. I believe there's like 8 of them, different types. Yes. Personality disorders is the last thing we're going to talk about. A personality disorder is classified by observing your patient's pattern of behavior, dysfunctional view of society, and level of sadness. So we have the psychopathic personality, which the patient has low morality, poor sense of responsibility. They don't care about anybody else. They don't respect anybody else. This patient is impulsive. They just want instant gratification for themselves and nobody else. They're gonna present with high frustration. They're gonna be super good liar. So they're gonna lie to you whenever you ask them, did you do your HEP? If you know that your patient has a psychopathic personality, that's most likely a lie. Not that you're going to tell them you're lying or anything, that's just so you know the personality disorder. There's going to be little guilt or remorse for all actions, inability to alter the behavior, even with punishments. This is a psychopath. The antisocial behavior patient will violate the rights of others. They will lack responsibility and emotional stability. Symptoms are typically seen before 16 years of age, and they blame everybody else but themselves. Oh, that teacher made me fail the test. My family messed me up, and this is the way that I am because of them, because they didn't do this and this for me. So that's the antisocial personality. The narcissistic behavior is incapable of loving others. They only love themselves. They're very self-absorbed. They're obsessed with getting all the power, getting all the success, and they have an unrealistic perception of how really important they are. They're the most important person to themselves. All right, these next couple of slides, basically I'm just going to cover really quickly the pharmacology that is used. The thing that I need you to focus on is not the name of the drugs, but the implications for us as PTAs. Like, what is my patient that's taking Xanax? What do I need to know? So these are anti-anxiety medications. The side effects of your patient is going to be drowsiness, sedation, withdrawal symptoms. The implication for the therapist, you have to implement alternative methods to decrease stress and anxiety, including exercise, physical activity, massage, relaxation techniques, and stress education. What are these effects here? Well, how will they affect our treatment? Let's say we want to do exercise for an hour with that patient.
For the person that's taking Xanax, they'll be kind of like drop and
Yeah,
fuzzy.
so
So
they'll
you
be
definitely don't want to do any of those.
exactly, or take the medication after the therapy, or do some other alternatives like relaxation techniques for them prior to you starting the exercises. So just take into account the drowsiness and all the side effects that they may have. Antidepressant agents such as Elavil, Nardil, and Prozac. I'm sure you've seen commercials for Prozac out there. Side effects are going to be sedation, blurred vision, orthostatic hypotension, tachycardia, insomnia, weight gain, death. They say that on the commercial as well. So you as PTAs must be aware of the side effects. You must also look for any signs of further depression and suicidal tendencies. We talked about suicide already and how you're going to handle that. And antipsychotic agents are indicated for schizophrenia, Alzheimer's, side effects, pseudoparkinsonism, meaning that the patient may exhibit signs of Parkinson, but they really don't have Parkinson. Constipation, weight gain, and hyperlipidemia. And PT, these agents assist patients to participate in physical therapy, so they're very important for us to make sure that the patient's attention is focused on the treatment at hand.
So you would want your patient.
You would want your patient to take this because it's going to increase your participation of that patient. And the last slide here covers bipolar disorder agents such as lithium, Tegretol, and Neurontin. The indications are for bipolar or manic depressive disorders. Side effects include confusion, ataxia, nystagmus, which you learned about today, dyskinesia, tremors. Long-term use of lithium may result in osteoporosis because it affects the calcium development. Implications for PT, the therapist should become familiar with the side effects of medication. So very, very important for you to know regarding those 4 slides, the side effects and what they're going to affect, how they're going to affect your treatments as PTAs. Any questions, guys?
President,
Yep.
Nystagmus, one last time, what is it?
Nystagmus is